Well, hello everyone, and welcome to our medicine grand rounds today. On this somewhat foggy and cold day, we are going to be talking about summer, our viral summer. Very cute topic, Peter. Thank you. I like it. I like when things go viral. I don't know if I want it to be a viral summer though. Peter almost needs no introduction. He is no stranger to the Department of Medicine and the School of Medicine at large. Peter holds so many roles. Most prominently, right now, he is a professor in medicine in the Division of Infectious Diseases and also holds the title of Associate Dean for UCSF regional campuses. He is most beloved in the Department of Medicine because he started the Immunocompromised infectious disease service and was really a pioneer in how we take care of our immunocompromised patients across the department and really across the institution. If I read all of the teaching awards that Peter had received, I think we would be here way too long and I would cut into Peter's talk. So I will just mention that Peter is a beloved teacher at all levels for the School of Medicine residents and to our faculty. He most notably has received the UCSF Henry J. Kaiser Award for Excellence in Teaching and is like an annual recipient of School of Medicine Teaching Awards for our medical students. He also has been an institutional leader in COVID, in monkeypox, in RSV. We depend on him for, all of our updates in what is going on in the world of infectious disease, which that landscape is changing nationally daily, which Peter may touch upon as well. So it is my pleasure to introduce Dr. Peter Chin Hong to give us some updates on what we can expect in infectious disease for this summer and beyond. Thank you, Peter. So pleased that you could join us.
Thanks so much, Michelle. I always get red when you read all these things about me, so I'm glad you stopped, so thank you. Thanks to everybody for coming, and thanks to everybody online. Today is a really dark day in American health because yesterday RFK Jr. announced that he's firing all 17 members of the ACIP, which is the Scientific Advisory Board to the CDC. So I've been really down for most of the time. It's been around for more than 60 years, and through different political administrations has always remained stable. And I think that instability is really palpable right now in all walks of life, particularly in infectious disease. So yes, so this is viral summer, and I thought I'd put a cute graphic here. These are the objectives, which I wouldn't go through, but I'm going to talk about three main viruses, COVID, H5N1 and Measles. And all three are sort of bubbling up to our consciousness, going up and down, but I think they continue to be threatening for the summer as we see. So right now, our respiratory virus levels are very low, and you can see that most of the states are in that sort of sky blue color, but I'll get back to that in terms of COVID, which is bubbling up. But summer is coming. I changed it from winter to summer. So let's start with COVID-19. So this is just an audience response question. How many COVID deaths did we have in 2024? And to put that in perspective, every year for flu, we have about 35,000 deaths a year, which is kind of a standard for, one could arguably say it shouldn't be 35,000, but certainly with COVID, we should have very few deaths given all of the tools that we have. So how many deaths did we have last year now that we're in this recovery phase of the pandemic? You can just guess in the audience. I'm looking at you. Which one? E? So we get some B's and C's. So it's actually around B, which is about 50,000 deaths, which is remarkable thinking that there's still a dialogue about whether or not COVID is not a big deal. It's causes less damage than flu, et cetera. And we'll get back to that. So right now we still have JN1. That's last year's vaccine for Novavax, and a derivative of that was a vaccine for Pfizer and Moderna. And this year we're likely going to have JN1. I'll talk a little bit more about that. But all of these viruses that are, these variants that are in the top 10 list, they're all descendants of JN1, which is important because that's what most people think the vaccine will be based on in the fall. So like I mentioned, although we have very low levels of respiratory viruses in the country, the levels of COVID wastewater is starting to go up. So I think it's not surprising because we've had 4 consecutive summers of increasing COVID that we'll see that again in the summer, but hopefully it will mean fewer hospitalizations, but people will be hospitalized. And right now we're seeing COVID as 2 diseases. One, like it's 2020 for those who are older, particularly those over 75, and one where it's really mild, which is most of the population, but still can cause people to leave work and not feel great. When you look at California, it's written as low for COVID wastewater activity, but it's very heterogeneous. So if you actually look at San Jose and Palo Alto now, it's moving from low to moderate. So it is coming. And why is it coming this summer? It's been the pattern, like I mentioned, for the last 4 years. It's been more than 6 months since most people were infected. More people are traveling. And right now there's a new variant called NB.1.8.1, which is again a descendant of JN1, but which is all Omicron. But this one in particular, right now in Asia, it's causing increase in emergency room visits in Taiwan, Hong Kong, Japan, increased hospitalizations, and even some increased deaths, according to authorities in Taiwan and Europe. It's increasing in many countries, including Spain and Netherlands. So I think it's just a matter of time before it increases here and we see the clouds darkening. And we've had actually this variant NB.1.8.1 detected already, even in California, in the Bay Area. But hopefully hospitalizations and deaths will likely be low overall, like I mentioned, except in some populations. In terms of treatment, I'm just going to focus mainly on Paxlovid because there's been a lot of questions, but much of our treatment paradigms haven't changed for COVID in the hospital, meaning that people come in, if they're ill, they get remdesivir. They may go home earlier than in the old days. If they require oxygen, they get prednisone or dexamethasone and anti-inflammatories if they're sicker. But Paxlovid has been very controversial because I think even amongst primary care clinicians, there's a hesitancy to use it. But my hypothesis is that we should really think about the shoulds and the coulds. So who should get Paxlovid? I think most of the people I saw in the last few months, including over the winter with COVID in the hospital, were those, they all had a similar refrain, which was they were older than 75 and they might have gotten 1 million vaccines early in the pandemic, but they didn't receive one in the last year. And that really seemed to be a unifying theme. Of course, I saw a lot of immune-compromised individuals as well, those who had recently been transplanted, et cetera. So we know that about 95% of those hospitalized in the last year were not vaccinated in the last 12 months, and most of those were older than 75. So I think those populations should really think about getting Paxlovid, even though drug interactions are problematic. And then other people could get it. It's FDA approved now, but considering risk factors and how immune compromised they are, might shape that whether or not you give it to them. But whatever you do, don't call it Paxlovid rebound, call it COVID rebound. And that's probably why Paxlovid got a bad name, because Fauci had it, Biden had it. And again, clinical rebound is different from just checking virus in your nose every day, like former President Biden and Jill Biden did. Their aides just checked their virus every day and they actually were feeling fine. So when you look at the data, and the myth is that my patients have a high chance of rebound if they take Paxlovid, but these are really based on small studies with mixed findings. When you look at the range, it's pretty broad in terms of rebound and Paxlovid, 20 to 32%, versus no treatment, 22 to 20%. But when you look at the more recent studies in the MMR, they actually are closer in terms of no treatment versus Paxlovid for rebound. So again, it's important not to average all of this out and not to give Paxlovid a bad name. And when rebound occurs, it's really brief and mild. So just some just quick summary of the data. We know that for people who are not vaccinated, the efficacy of Paxlovid could be quite good. And this is the original data on which it got the EUA and then the FDA approval with 90% prevention of 89 to 90% prevention of hospitalization and death in unvaccinated people. When you look at younger populations in the Pfizer EPIC SR study, there wasn't much of a difference between the people who got Paxlovid and the people who got placebo. So that's why for a younger population, we don't typically recommend it anymore. And the median age in this population was 42. I think the older population is controversial, and part of it was fueled by this research letter to JAMA, where in Ontario, they had a very strict cutoff rate at age 70 for whether or not you can get Paxlovid or not. So the investigators looked at the slope between just after age 70 and before age 70. And they said that, well, it didn't seem to really make a difference whether or not you got Paxlovid or not if you're older in terms of hospitalization. But this was actually, even though it was just published in 2025, it was based on 2022 data where 90% were vaccinated. So one would say that it's not really generalizable to our older population right now. The people who I saw last year who were older than 75 and didn't get a vaccine in the last year, because those were not the population. That was not the population that was studied in Canada. There's a new drug called Shakova or ensitrelvir that a lot of people had a lot of hopes for. The reason why it was just once daily, didn't have any drug interactions, no Paxlovid mouth, you didn't have to chew gum or eat cinnamon to try to get away the taste. And it's been an FDA fast track designation, fast track, since April of 2023. And part of the reason why it hasn't been, even though it's been approved in Japan, Singapore, and other countries, it's not been approved here because they wanted to have more robust studies. And I summarized 3 of the studies here. This graph is from the first study, which looked at standard risk or low risk populations. And you can see that kind of like within 3 days, if you took Paxlovid, there was 1 day decrease in symptoms. They looked just at I think a constellation of a few symptoms as an aggregate measure. And there was a difference in viral load reduction. So it's kind of almost like Tamiflu. If you take Shakova, you can feel better a day faster. But that wasn't enough in terms of approval. So they did a high-risk study led by Annie Lukemeyer that looked at that people with at least one risk factor, pretty large study, and a youngish population. And they saw that they looked at 15 measures in aggregate this time, and there was not much of a difference in reduction. But again, with the 6 symptoms as above, it continued to show a reduction in symptoms. So whether or not this would be, if it ever is approved, whether or not it would be an option instead of Paxlovid for people like the patients I see a lot of who are immune compromised and have potentially a lot of drug interactions, you know, I would probably believe it if I had no other options. One interesting study with ensitrelvir was this household contact study, as just presented at the CROI meetings. Again, a very large study, randomized control again, took meds within 3 days. And it was pretty remarkable that even though the absolute number wasn't really exciting, but that it did reduce household contacts from acquiring COVID. So 3% versus 9%, or 67% reduction. So the bottom line is, I still think about Paxlovid as a really good choice for treating early COVID in the right patient. And particularly with people who I'm really worried about, you know, if they can't take Paxlovid, of course, I can try to get them into an infusion care facility to give them remdesivir for 3 days. We sometimes use convalescent plasma for immune compromised patients as well. Try to treat people early, but that requires an early diagnosis. We mentioned the should population, those over 75 and who haven't gotten the vaccine last year, which is actually more than 50% of the over than 65 population. And people complain about the $1,500 to $2,000 bill that they sometimes get at Walgreens. But even for people with insurance, there's this program called Access, where you can fill it out in 2 or 3 minutes after the prescription and really get it at very low cost. I don't think it's very well known or even well used or often used, but that's something that I think is really important for our patients to know about. In terms of vaccine updates, mRNA vaccines have been under a lot of assault in the last few weeks. And of course, there's the Novavax vaccine, which has also been under assault, but not quite as much as the mRNA vaccines, because it's created using traditional protein subunit technology. So what is our current COVID vaccine? Our current COVID vaccine is based on one type, Omicron. Last year, they were all JN1 and analogs. This year, it's expected to be JN1. The advisory board, first of all, the advisory board for the FDA approved it, or all kind of decided on JN1 for this year as well, with a priority group of 65 and older. Whether or not who will get it this year, I think remains an open question, because these vaccine guidelines are, as you know, under a lot of change right now and a lot of discussion. So what has happened? So before, everybody 6 months and older was eligible for the COVID vaccine once a year, but the FDA commissioner announced on X that a few weeks ago that the fall vaccines were only available to those 65 and older or under 65 with comorbidity. They didn't say what comorbidity meant, but if it's based on traditional COVID comorbidities that we defined, that's probably about 100 to 200 million people in the US, about 1/3 of the population. But again, it depends on how insurance, defines that as well. So then after that message on X, then RFK Jr. then said that pregnant persons and children are no longer eligible. Then the CDC responded by saying, actually, children are eligible with shared decision clinical making, which means that there has to be a discussion in the office about whether or not the child will be a good fit for the vaccine. And we know that historically, when you have these barriers like shared clinical decision making, that reduces access, and a lot of people can't get vaccines. For example, you can go to Walgreens and have shared clinical decision making, which is a lot of the ways in which people get vaccines now. So when I made the slide, just updated it, this particular slide yesterday morning, we know that the CDC advisors called ACIP was supposed to meet June 25th to 27th. That's still going to happen, but as we know, what happened yesterday was that, and as I mentioned earlier, that all 17 members of this advisory board were fired. And what it means is that in 2 weeks, because they're going to keep this meeting, they're going to hire a whole slate of 17 new advisors without, you can't really vet somebody in 2 weeks that well. So I think a lot of people are very nervous. There have already been splinter groups that have been set up to try to have some sort of evidence-based group that people might trust. But of course, what it means is that there's no central voice anymore. There's a lot of different voices. You'll be hearing a lot of different recommendations from a lot of different people. And it's going to be really tough for your average person, even us, to know who to trust. So who should really get a COVID shot yearly? I really think those 65 and older, regardless of health status, and that's currently still going to be approved. Pregnant people for sure, and that's under, it seems that that's not going to be approved. And the reason why it should really be a must is that pregnant people can get very serious disease. They are relatively immune compromised because their immune system gets damped down in common terms so that the fetus can grow as a foreign body. So it's almost like a mild transplant. And that's why they are somewhat immune suppressed. And of course, we rely on the mom's antibodies to cross the placenta to give protection to the newborn, because under 6 months, there's no you can't give a vaccine, and also the immune system isn't mature enough to develop their own antibodies. So pregnant people are important for themselves as well as for the health of the newborn. Infants under 5 are now, at least, who knows what will happen, but it's also under threat. We know that even in the last season, I was shocked to know that infants have the highest rate of emergency department visits. When you look at the green line, 0 to 4 years, even higher than some of our older populations, 65 and older. So it seems, if we're thinking that if we're protecting older individuals, we should really think about that age group as well. We also know that infants under 5 have a high rate of hospitalization, and actually the second highest COVID-19 hospitalization rates in 24-25. So 150 infants under 5 still die every year of COVID, even right now. And 32% of these have no comorbidities. So, if you think about people with comorbidities, when you think about infants, they're not all covered for sure. And of course, those who are very immune compromised, they'll still likely be able to get the vaccine. And I think they should. And under 65 with comorbidities are also eligible. Another option that's not been well used, but I think it is FDA approved, is long-acting monoclonal antibodies. Because it's really tough to give. So in other words, the factory makes the antibodies for people who can't make it themselves, who have multiple myeloma or recent transplant. It's not a substitute of the vaccine, but we do have it available. It takes about an hour to infuse, and you have to observe for an hour. So it's really tough to give, and it costs about $2,000 if insurance doesn't cover it. And if the variants change, you have to also change the formulation of the long-acting monoclonal antibody. So at the end of the day with COVID, I think it's still very relevant in 2025 in the summer. We'll likely see an increase, and there's still a lot that we need to do for COVID. So I talked to Carlos Silvery, our friend of our department, to give his insights on what we still need.
Well, COVID is, as you know, for us here to stay, but the virus continues to change. There are increasing levels of immunity in the population, but it's still causing significant disease and mortality and morbidity, especially in older individuals. I think the most important thing is we need better vaccines. The vaccines we currently have, as you know, are not sterilizing vaccines. They prevent you from getting severe disease, but also it produces significant waning immunity. So we clearly need better vaccines, and there's some recent scientific data suggesting that part of the reason for that is that it may not be creating the kind of memory B cells that we need. So better vaccines is clearly an important topic there. The other one is therapeutics. I mean, the therapeutics we have, you and I do HIV. I think about, remdesivir. I think about, Paxlovid, a little bit like I think about AZT or DDI and HIV. I mean, they're antiretrovirals, but they're not the best drugs available. We need discovery into better drugs for COVID. But the same thing can be said about influenza. I mean, all respiratory viruses are in the same category. And quite frankly, one of my biggest concerns right now is, H5N1, and it's beginning to spread among people. And what are we doing? I clearly think we're not prepared. And with the misinformation and the lack of trust in vaccines, I worry that we're not prepared as a society should there be an outbreak of H5N1 in the ensuing months.
Great. Thanks so much, Carlos. That was awesome.
So it's really wild when epidemiologists do memes. So this is from your local epidemiologist taking the White Lotus, picture, watching CDC restudy vaccines and autism despite decades of research saying there's no link. So Carlos talked about H5N1 influenza, and let's talk about where we are right now, just before we start the summer with H5N1. It hasn't been in the news. But is it not in news because people aren't meeting and disseminating that to the public? Or is it not in news because nothing is going on? Sometimes it's hard to say. So just to recap, everyone, H5N1 influenza has been around for about 30 years, with now mammal crossover into about 50 mammals. Humans are incidentally infected with about almost 1,000 cases globally, I think more than 1,000 now, with about a 48% fatality because it's not where our immune system isn't used to H5N1, just like we weren't used to COVID in 2020. So since in recent times, however, since 2020, when you talk to veterinarians and animal scientists, something happened where this H5N1 underwent a mutation and started to affect birds, wild birds and migratory birds in particular. And then it started affecting our animals. So since 2024, as you know, there have been more than 1,000 dairy herds affected, 17 states, and more than 174 million poultry affected in 51 states, so pretty much everywhere. And there have been 70 confirmed human cases in the US since 2024. 6 cases just doing surveillance and 1 death in Louisiana. When you look at the epicenter of H5N1, it's California. We are the largest agricultural state in the country, and Washington State. But it also, when you look at the pattern here with the blues and the light blues, they also form a pattern where birds migrate. Picture that in your mind, and we'll come back to that in a second. So just some recent updates with H5N1. We know that asymptomatic infection occurs. There's been a study in vets who took care of these animals, and about 2% of them were infected without any symptoms. We know that dairy workers who have a lot more exposure, when you look at the studies, about 10% of them are infected without any symptoms. We know that the time before it can really latch onto human receptor cells in the airways is getting shorter. There was a study at Scripps in San Diego showing that it actually didn't take very much for this current H5N1 to mutate to allow it to more easily latch to our epithelial cells in our airways in humans. That's the reason why we aren't getting very sick, because it's not a very easy entryway into the human bodies compared to some of the other evolved respiratory viruses like human influenza. But from this study, it's very, very close. We know that bird flu continues to mutate. There's this type called D1.1. That was the type that the person in Louisiana had who died. That was the type who a teenager in British Columbia had, who was in the ICU with bird flu. And it was detected now in cows. So this was really in wild birds. And what it shows is that, we are a threat not only to the animals that we interact with, but also animals that are flying all over, affecting cats and cows and so on. We know that it's, influenza H5N1 continues to exchange genes with other viruses around. And that was the worry over this last flu season, that it will just exchange genes with a human flu and then make it easier to enter human bodies. In Merced, they had to kill more than 100,000 ducks actually, because H5N1 exchanged genes with another influenza in the birds and caused this mutation called H5N9. What it showed me was that it's very capable of exchanging genes that people feared. And what's happening now? Well, we know that cows are being reinfected. It's kind of been kept very quiet and not published, but at least in Idaho, from the reports, there are cows who had it before and they're getting it again. So it may mean that even if they have protective antibodies, that it's not lasting very long. And it also means that it's probably in our environment with or without migratory birds. But most concerningly, we don't have the tools anymore. So as I mentioned, mRNA vaccines are under threat. And one of the biggest examples of that was the canceling of a $766 million Moderna vaccine contract that was meant to have a very nimble mechanism for making H5N1 or avian flu vaccine very quickly, like we did with COVID. And essentially, mRNA vaccines are really remarkable because it takes about 3 months to make a vaccine from scratch, as opposed to more than 6 months with a traditional vaccine. And when a virus evolves, you can essentially just cut and paste the code and put it in a bubble and send it into the body. If you cancel all of this development, it really sets us back, not only with bird flu, but with lots of other viruses of threat. In the last 4 pandemics of influenza, they've all had its origins in avian flu. So it's not like we're, raising our hands up to panic people. It's just that history repeats itself. But luckily, there's been no proven human-to-human transmission yet. The risk is still low to general population because the virus hasn't evolved to really enter our bodies more efficiently. I thought it was really wild that eggs are so expensive now that people are stealing them. So there have been lots of memes about that. So 100,000 eggs are stolen in Pennsylvania amid shortage. And then this is really speaking to the bird migration patterns and possibly why California was so affected because of that particular highway that these birds take from the Arctic, where they were mixing with other birds that probably came over from Asia and then coming down. Not only resulted in dairy cows and chickens being infected, but also zoo animals. So San Francisco Zoo had a few animals who died, usually birds and cats. Washington State, Oregon as well. They're all related to the specific flyway. So the bird's already gone up north to mate. So the question is whether or not when they come back down in the fall, if we'll see more disease activity after it's evolved for some time. I think that remains to be seen. So I spoke to the best source of information to get his ideas, who's a vet. He's really been a great voice of reason. As human doctors and in human health, we don't talk enough to animal veterinarians, and I think we need to continue to do that. So I talked to Michael Payne about what he thinks about bird flu coming back.
Endemic. So we're now seeing it. We can now find it inside small animals, cats. We're getting very, very high levels of virus being collected from the cloaca, from the bottom from the GI tract of non-migratory birds, sparrows, starlings. It's circulating right now outside of our migratory waterfowl path. And that means that I think the disease is endemic, at least cattle and inside wildlife and poultry inside the United States. It is mutating. We've had several different mutations. And we continue to go ahead and have new detection in Southern California right now. Where those new detections are coming from is an area of intense discussion and interest in my world right now. We have dairies that have not been released from quarantine for over a year, not very many of them. We have dairies that were infected, went through the worst of it, and now have positive bulk, and then were released. They had 3 weekly sequential PCR tests that were negative, were released from quarantine, now are under quarantine again because they have either they simply detected the virus and they have no clinical cows they can detect, or we actually have clinical heifers. Why that's happening is an area of intense interest. It may be that the environmental load is just still there. It's residing inside wet areas in environment. Maybe because the protective antibodies that were developed in cattle that were infected don't last longer than a few months. It may be that these are new cattle, young cattle that were shipped off farm and then for raising, then returned at about 2 years of age. Either their antibodies have degraded or they were never infected and now they're exposed to it. So I think this is far from over. Desperately from the dairy industry and poultry industry, USDA is to go ahead and approve cattle vaccines and poultry vaccines exist, but have not been released.
So the reason why we haven't vaccinated cows and poultry is that it's bad for trade. So because you have to declare that because they turn out positive for the antibody tests and they're worth less on the market. So the trade barrier is a very real one for vaccinating animals and therefore protecting human health. So impressor with something expensive. So how do you keep yourself safe from H5N1? Get your human flu shot every year. Don't handle sick cows or animals. Don't drink raw milk or cheese. Don't feed pets raw milk or meat. We've had several deaths in cats. Wear PPE handling sick birds and banyan flax. In fact, the person who died in Louisiana had backyard chickens that the person handled, and that's how they got it. So what can health professionals do? I talked to Michael again about this.
That are interested in being able to perform appropriate diagnostics. There's only one laboratory inside California that can actually run, funnily enough, a human samples for HPAI. So if our human colleagues work with undocumented workers, with agricultural workers on the livestock or poultry side, if they're associated with clinics or they they're treating or conversing with agricultural workers that have symptoms that might be associated with it. So flu-like symptoms, mild flu-like symptoms, conjunctivitis, or who were reported dead in their home. Those would all they should trigger a call to California Department of.
Great. Thanks so much, Mike.
Thanks for your interest, sir.
So let's turn our attention now to measles. So measles cases continue to increase everywhere, but apparently the outbreak is slowing down in Texas. What was really interesting, I don't have time to talk about, is that more people actually did get vaccinated. When you have an increase in cases, even with COVID, we know that drives vaccination rates. People want to prevent something they can actually see instead of something hypothetical. But there have been more than 740 cases now in the West Texas outbreak, 94 hospitalizations. It is really remarkable because some of those areas have vaccination rates as low as 40%. Nationally, there have been outbreaks in 33 states this year with more than 1,000 cases, mainly children 5 to 17. Of the people who've gotten measles, 97% have been unvaccinated or of unknown status. There have been 3 deaths, 2 kids in Texas, one adult in New Mexico. It's the first kid death in 20 years, the first adult death in 10 years. And the fact that we usually see 1 to 2 deaths per 1,000 deaths, 1 to 2 deaths per 1,000 cases means that the number of cases is probably much larger than the official numbers, which is likely true because if you're homeschooled, you don't have to report anything officially. And we know that a lot of the cases in Texas were in the homeschool population, which is what parents sometimes do to escape vaccine mandates, even though they can get exemptions. So this is easily exceeding all the cases for all of last year, which were 285. We have over 1,000 so far this year, and it's near a 30-year high. There are also outbreaks in Mexico and Canada, close to where our outbreaks are. It's bleeding over. And the rest of the world is really on fire as well with measles. What happened is that the COVID pandemic made people miss their measles shots, kids. And so that's driving a lot of measles rates around the country. So there's high risk globally, even in the UK. So, people traveling abroad should really make sure that they're up to date on their measles vaccination as well. As you know, measles is highly contagious. If you walk into a room, if somebody with measles is in a room and then leave the room 2 hours later, you can walk in the room and still get measles if you are under vaccinated or unvaccinated. 9 out of 10 of people get measles if they're at risk in the presence of someone with measles. Even in the Shakira concert recently in New Jersey, there was a measles case and everybody went crazy. So that's to tell you how big impact it has, not only in the people going to the hospital and dying, but people who are staying home because you have to quarantine for 3 weeks if you're unvaccinated, not 5 days. And somebody has to take care of that person too. So the cough, runny nose, red eyes, fever, and rash. Pneumonia is about 1 in 20 cases. Brain infection, there's a long COVID version of measles called SSBE that can happen about 7 to 10 years after recovery. So it's not a walk in the park. So in terms of treatment, I got all my information from Nanny McPhee. I'll just play it right here.
Actually, I'm not sure it is measles.
How can it be anything other? The chalky white faces, the livid spots, the temperatures of 120 degrees. I've seen it time and again. Measles. Definitely. Open.
I'm not taking that.
Then you will not get any better. Believe me. Open wide. Wider.
Son, spit it out.
You'll have to swallow it sooner or later, so I suggest you get it over with. Very good.
I think that's how we all feel right now. And this, fiction becomes truth because, as people may know, RFK Jr. has been promoting vitamin A and cod liver oil to treat measles or to prevent it. There is no treatment for measles, it's only supportive. And the whole vitamin A issue, there is a difference in mortality in vitamin A, but it's likely in places with true vitamin A deficiency. As we know that vitamins, getting too many vitamins can be dangerous, but also if you have enough vitamins, getting extra doesn't really help. Vitamin A does help with people with measles to reduce ophthalmia, which is dry corneas and conjunctiva. And there's been a systematic review in very highly represented by developing countries where there's no effect on mortality, but small studies in resource-poor countries, 2 doses of vitamin A reduces the mortality from 10.7% to 1.9%. But studies in resource-rich country studies like Italy showed no mortality benefit. But nevertheless, the CDC does recommend vitamin A given this, data. We give it to hospitalized patients, usually kids with severe measles, and the dose is 200,000 international units for 2 doses if more than a year old. So if you look at cod liver oil, 1 teaspoon is 4,500 international units. So you need to have a lot of vitamin A, a lot of teaspoons of cod liver oil. But cod liver oil also contains vitamin D, omega-3 fatty acids, vitamin E, K, and calcium. So you can see why if you try to make up the high doses of vitamin A by giving these other ways that people can get into toxicity, which occurred. So we don't have really good treatment for for measles. Ribavirin has been studied, only positive in vitro studies. But I think for some patients, we sometimes talk about it. And budesonide has definitely not been studied nor recommended, but it was recommended by our federal leaders in the Texas outbreak based on a report of somebody in the community. So how do you protect yourself from measles? Vaccinate with MMR. There's one approximately age 1, 12 to 15 months, and then the second dose is at age 5 to 6. You can get it younger than that in the context of an outbreak, but then you have to repeat the series. I think the boosting issue has been coming up because people are worried now as we get more and more cases. So if you're born after 57, before 57, you would have gotten it naturally, and that's lifelong immunity. If you're born between 57 and 68, there was a less effective version of the vaccine given then, which was a killed vaccine. And if you only gotten 1 shot, just basically think about getting a second shot. If you're not really sure, you can get your measles titer checked by your provider and definitely educate others about all the things that we talked about. So what's next? I think, COVID, like Carlos said, is here to stay. And although it's not going to probably kill 100,000 people as in the early estimates on an annual basis, it is probably going to be very similar to influenza at the minimum, which is very similar to diabetes. And kidney deaths. And to think that we never had this threat before 2020 is really remarkable, that that's suddenly part of our lexicon and our threat. I think we continue to need to be vigilant, not just for H5N1 or other, but for other infections as well. This disease X was a placeholder by the WHO, representing the knowledge that a serious international epidemic could be caused by a pathogen currently unknown to cause human disease. And most experts, even before COVID, think that it will be a respiratory virus like bird flu that is currently circulating in animals. So we need to strengthen primary care, research and development, spend more and spend smarter, and focus on prevention, invest in prevention, and share data, all of which are under threat right now. No, I knew you were going to say that. I did that very quietly to see if anybody would notice, but I can't stop saying it. So I talked to Bonnie Maldonado, who's a really good friend and colleague from Stanford, to really give her ideas on, you know, what we really need for the next pandemic.
We've learned, the good news is we've learned a lot from COVID. We've learned a lot from flu. We have lots of technology. I don't think we are going to have a problem understanding how to harness technology. But what we need to do is learn how to implement technology, and we also need to learn how to do surveillance the right way, globally and quickly. So as an epidemiologist, I can tell you that all of us card-carrying epidemiologists really believe in the power of surveillance, and everyone thinks it's boring, but it is really, you need to get out there and do the spy work, the groundwork, just get the data out as fast as you can, get it back and organize it at a global scale. We are capable of doing that today, especially with AI. And then building technologies is not hard to do. The hard part is implementing and disseminating technology so that there is global equity. What we saw with the pandemic was that we moved relatively fast, but we got hung up in how well we were able to disseminate technology and information. So I think those are the major areas. And then the other big area would be really, how do we communicate effectively? We're talking about not just at the local, state, or national level, but at the global level. How do we communicate so that people understand that what we're doing is really laying the groundwork for understanding what might come along the way? How do we address the immediate issues, the medium-term issues, and the long-term issues? So we have the scientific expertise. We just have to learn how to apply it and apply it equitably across the globe.
Thanks so much, Bonnie. That was great.
So Bonnie talked about surveillance as being really the key part. And somebody asked me today, you know, how do I feel about the ACIP being fired? And would it mean that, you know, all of us will have to start communicating about recommendations again, like we did in COVID? And I thought that it sounds great in principle, but if you're going to dismantle data sharing, or you're going to, you know, decide what data to share or not, it's going to be really, really tough. And like I mentioned, there's going to be a lot of splintering and different groups saying different things now because it's become so politicized. So in terms of my take-home points, I know people can only remember 3 things, but I kind of clumped them up into many things in 3 bullets. But in terms of COVID, I think we're going to see an increase over the summer. Ensure that older patients, very immune compromised individuals, pregnant people, and under 2 vaccinated for sure. Don't forget about early antivirals like Paxlovid, especially if someone's under 75 or over 75 and not vaccinated in the past year. We know that H5N1 is likely endemic, even if the birds don't have H5N1 coming, but they probably will when they come back from the north for the after the summer. Cases will likely rise later in the year. Be vigilant and contact IDA or CADPH for confirmatory testing if needed. And then in terms of measles, those cases will continue to increase as the vaccination rates decline. There's a high risk globally, not just in the US. So there have been as many plagues as wars in history, yet always plagues and wars take people equally by surprise. So I thought I'd end on a high note, even though it's kind of an existential message, and hopefully, I don't think it will embarrass Sam to show one of our Department of Medicine get-togethers, which I think, when after the pandemic was one of the first times we got together, and Sam sings. Just a few seconds. When you fall in the forest, there's nobody around. Do you ever really crash or really make a sound? When you're in the forest, there's nobody around. Do you ever really crash or even make a sound? Did I even make a sound? Did I even make a sound? It's like I never made a sound. Will I ever make a sound? Yeah, we should have him sing it live. So it's an existential statement from Dave Evan Hansen. If the tree falls in the forest, and you're not there to hear it, did it really happen? I think that's what's happening right now in this country, and hopefully, we would make something happen. And again, I think we're reaching an inflection point of activism again, even though it's dangerous. It's more dangerous than before. So I encourage all of us to do so. So thanks very much for your attention.
Not heartening, but inspiring. And I really appreciate you sort of standing up for your advocacy and what you believe in terms of what we need in terms of science and data reporting and vigilance, and our part in being the voice of truth and science and what we know and how we should protect ourselves. So I appreciate that. Thank you.
Thanks so much, Michelle.
I recently got back from a national park vacation, and every evening we would see the bats flying around, and we had to have conversations with our children about okay, if you see a bat on the ground, what do you do? Or more importantly, what do you not do? And it was like,
I like how you ask as a question too.
Yeah.
Open-ended question,
Didactic method. Bats have viruses. And I was like, good, we have taught you well. So I am very curious. I've been following H5N1 bird flu very closely. And I'm curious if you can do a little crystal ball prognostication for us. I was interested in the duck example, and yet it has been so long that we've been living with H5N1 and that hasn't happened in humans. Do you think it's just a matter of time because it's such a mutationary virus that we will get one that affects humans and is transmissible between humans? Or do you think it's more likely actually there's going to be some other novel virus that we don't even know about?
I think that's a great question. I think the reason we haven't seen it too much is that until now is that, it's just like the more transmissions you have, the more mutations are likely going to happen. And it hasn't happened yet because there probably hasn't been as many transmissions. But with time, because it's a pandemic in birds, and I think the big thing happened in 2020 when we were all kind of distracted with COVID. What was happening with bird flu is that the birds, it mutated somehow, and it allowed birds to transmit it. And that's when seals were dying in South America and in South Africa and all of that. And there were enough transmissions occurring, but it probably does take some time for it to mutate, but probably not enough to enter our body. So I think it's a matter of time.
More human transmissions we have, the more likely that one of those human transmissions is going to do the duck thing.
Yeah.
Give us an H1 something that.
Yes, I think this is probably going to be a good as candidate as any, because all the forces are in place, not just the biology, but the politics and the trade, and the fact that it's not just human health like COVID, it's human health, animal health, Department of Agriculture, federal leaders, global leaders pulling out from the WHO. It almost takes a perfect storm for things to happen. And I feel like it's coming. It's not like happening tomorrow, but it probably will happen. And I feel like this is a pretty good candidate for that to happen. Rebecca.
Thank you. Thank you, Peter, for that very interesting and quite bleak talk in terms of kind of where we're at. I'm curious, you have a very public way to do advocacy, but for those in our community who don't, do you have suggestions for how people who are feeling like we should stand up for science could do so?
Thanks for such a a great question, Rebecca, and such a tough question because I think in COVID times it was easier in a way to stand up for science. We all felt under threat, and I think we were able to rally. And so if we take that playbook, which was a combination of different things, it was writing op-eds, going on radio, TV, newspapers, marching in the streets safely. I think those are so tough to do right now because things are so evolving, particularly in the academic environment where our institutions feel a threat. So it's almost like you have to check with somebody before you can do something. Like in the old days, you didn't have to, because our own institution, our own department is at risk. But I feel like with what's happening with, not even with health, with immigration and with all those aspects under threat, that people are coming together. And I feel like, yes, it's the time to probably start doing that again, but it probably comes at greater risk than in COVID, unfortunately. The KQED and NPR just put out a article on how to protest safely, and every time they do that, I know that they did that during COVID. So I feel like the fact that they're seeing that happening now, and Waymo stopped, going in many places because of protests now in San Francisco, even though much of it is happening in LA. I feel that the writing is on the wall, and I feel like we're going to be called again. And it's that siren call that you kind of know when it's right, and I feel like it's coming back again. No easy answer except multimodal and using trusted people from the community is kind of like the basics of activism, and then working in health, working with people who are doing a lot of policy and law, which I know department and our university is doing. We need to continue to do that. I think COVID, we worked effectively because it wasn't just us, it was us working with public defenders and people who kind of knew what they were doing on that side, and translating our good thoughts into policy or action. But it's a different time, and I can't say I know what the formula is, but I feel like it's coming.
Paul Fitzgerald, thank you, Peter. With the fairly high COVID rebound rate after Paxlovid, shouldn't we be treating people for longer than 5 days with Paxlovid, at least those who we treat are with severe illness?
Thanks, Paul. That's a great question about the duration of treatment. I think people are studying that now, and the information I know so far is that it doesn't really give you more bang for the buck, but we sometimes do that for immune-compromised individuals anyway, rarely, but not standard because it's not something. But yes, I mean, I think in other parts of medicine, we sometimes go off-label and treat a little bit longer. I think unofficial people are doing that sometimes, but it has to probably be studied before we put that into prime time. And I know the studies are ongoing, but I haven't really seen any results. And part of the reason why is because as the rest of the population continues to be very COVID experienced, it's hard to get a really good control group anymore of people who are, less experienced, and then to see that there's a benefit of Paxlovid. And in fact, in that study with the new antiviral ensitrelvir, where they showed no benefit in the high-risk population, except for one day if you looked at 5 symptoms. There was a nice editorial written in the journal about the fact that we need to think differently about how we conduct COVID trials, because again, so many people experience that you have to either find a group, have a different measure of success, basically. So if we think of it that way, I do believe that there's probably a group that would benefit probably from a longer than 5-day treatment. But we have to do those studies well. But it makes a lot of sense.
And thank you to Peter.
Thanks so much, Michelle.